thanks, Aegis, for allowing me to present today. All right, I have no disclosures to report. As we all know, readmissions are becoming more and more important in our field with recent government mandates that allow CMS to reduce payments to hospitals that have high readmission rates. And now with that data available, the readmission rates are being used as a quality indicator. Prior studies have identified readmissions after bariatric surgery as the most costly aspect of bariatric surgery. And in the very near future, readmissions can impact practice trends, reimbursement, accreditation, and competitive advantages. So how do we prevent readmissions, and what are the risk factors that we know? Previous studies have shown that major risk factors after bariatric surgery include open surgical approaches, prolonged lengths of stay, serious comorbid diseases, multiple preoperative medications, and clinical depression. In other surgical fields, surgeon volume has been associated with improved outcomes and fewer readmissions. Specific to bariatric surgery, in a recent review article, there were 11 studies identified that demonstrated a correlation between annual surgeon volume and patient outcomes. But only 2 of these studies examined the 30-day readmission rate, and neither of them were specific to laparoscopic Roux-En-Y gastric bypass passes. So the objective of our study was to see if there's a relationship between annual surgeon volume and 30-day readmission after gastric bypass. So to do this, we used the BOLD database from 2011. We included all patients that had a laparoscopic gastric bypass. We excluded any cases that were revisions of prior bariatric surgery or cases that were not laparoscopic. And we used the primary surgeon identification number that's a variable in the database to classify surgeons based on their annual volume. And we defined high and low volume based on a cutoff point of 50 cases per year. So we used a multivariable binary regression models to control for patient demographics and comorbidities. And the primary outcome of our study was 30-day readmission rate with secondary outcomes of 30-day mortality, reoperation, and complications. So we identified 32,521 patients. The mean age of the entire group was 45.7 with a mean BMI of 47. 21% were male. We identified 216 high-volume surgeons who performed 21,379 gastric bypasses and 617 low-volume surgeons that performed 11,142 gastric bypasses. So here we compare the patient's unadjusted demographics and based on the surgeon volume, and we see that there are some differences in 2 groups. For example, age had a statistical significance, but I think this is mainly due to the power of the study because the actual difference is 45.5 versus 45.8, so unlikely to have any real practical difference. But if you look at ASA classification, for the low-volume surgeon group, 74% of those had an ASA score greater than 2 compared to almost 81% of the high-volume surgeons. But then interestingly, high-volume surgeons had a greater proportion of patients with private insurance. So looking at the comorbidities specifically, there are some differences in between the 2 groups, but relatively overall, they're similar. But there was differences in angina with 3.0 versus 2.6 between the 2, as well as functional status impairment, hyperlipidemia, liver disease, obstructive sleep apnea, and pulmonary hypertension, and tobacco use. So comparing the 30-day outcomes based on the surgeon volume, low-volume surgeons had higher rates of readmission at 6.1% versus 5.2%, reoperation at 3.7 versus 3%, mortality at 0.2 versus 0.1, any complication at 10.5 versus 8.6, and an anastomotic leak at 0.6 versus 0.4, all of which were statistically significant. So then using our logistic regression model to account for demographics and comorbidities, we came up with the odds ratios and confidence intervals here, and we were able to show that low-volume surgeons are independently associated with higher readmission rates, which was the primary outcome of our study. And as has been shown before, low-volume surgeons were also independently associated with 30-day reoperation, mortality, complications, and leaks. So our study does have several limitations. We use the largest nationwide database, so it's risk for selection bias. And our study was limited to only 1 year of data, but if we were able to use multiple years of data to aggregate the surgeon volume, our findings could be more robust. And finally, we limited our results to only 30-day outcomes, so we missed any readmissions or complications that happened after that time. So we've shown that readmissions after gastric bypass are significantly associated with annual surgeon volume. And as has been shown previously, patients of low volume surgeons are more likely to develop complications. Performance of the gastric bypass by high volume surgeons may decrease hospital readmissions and decrease healthcare resource utilization. Thank you.